Hello and welcome to Minute MRCP. In this video, we'll review the 2026 NICE guidelines for the management of type 2 diabetes mellitus, including HbA1c targets, first-line treatment, special clinical scenarios, and cardiovascular risk reduction. Let's start with HbA1c targets. NICE recommends that HbA1c targets should be individualized and agreed upon with the patient. HbA1c should be checked every 3 to 6 months until stable, and then every 6 months thereafter. For patients managed with lifestyle measures alone, or with medications that do not cause hyperglycemia, the target HbA1c is 48 mol per mol, which is equivalent to 6.5%. For patients taking medications associated with hyperglycemia, such as sulfonylureas or insulin, the target HbA1c is 53 mol per mol, or 7%. If HbA1c rises to 58 mol per mol, or 7.5%, NICE recommends reinforcing dietary and lifestyle advice, reviewing medication adherence, aiming for an HbA1c of 53 mol per mol, and intensifying treatment. Targets may be relaxed in older or frail patients on a case-by-case basis. Now let's discuss initial drug therapy. The major change in the 2026 guideline is that 2 core medications are recommended. The first core drug is modified-release metformin. This should be started first and gradually titrated to the maximum tolerated dose. The second core drug is an SGLT2 inhibitor. This should be added as soon as the patient reaches the maximum tolerated dose of metformin. If metformin is contraindicated or not tolerated, an SGLT2 inhibitor can be used alone. Next, let's look at important special situations. For patients with established cardiovascular disease, subcutaneous semaglutide should be added to the 2 core drugs because of its proven cardiovascular benefits. For patients who develop type 2 diabetes before the age of 40 years, consider adding a GLP-1 receptor agonist or Tirzepatide to the 2 core drugs. Early-onset diabetes is associated with a higher lifetime risk of complications, so more intensive treatment may be appropriate. In chronic kidney disease with an eGFR between 20 and 30 milliliters per minute per 1.73 square meters, metformin is contraindicated. In this situation, use dapagliflozin or empagliflozin together with a DPP-4 inhibitor. If the eGFR falls below 20 milliliters per minute per 1.73 square meters, both metformin and SGLT2 inhibitors are contraindicated. In these patients, a DPP-4 inhibitor is recommended. For people living with frailty, modified-release metformin remains appropriate, but SGLT2 inhibitors should only be used if the risk of adverse effects such as volume depletion or hypertension is low. Now let's discuss what to do if glycemic targets are not achieved. In patients without significant comorbidities, the standard next step treatment is a DPP-4 inhibitor added to the 2 core drugs. If a DPP-4 inhibitor is contraindicated, not tolerated, or ineffective, options include a sulfonylurea, pioglitazone, or insulin-based treatment. Remember that pioglitazone is contraindicated in heart failure. Obesity deserves special consideration. If a patient has been taking the initial therapy for at least 3 months and still requires additional glucose lowering, consider adding a GLP-1 receptor agonist or Tirzepatide. These drugs provide both glycemic control and significant weight loss. If control remains inadequate, a DPP-4 inhibitor may be added. If this is unsuitable, consider a sulfonylurea, pioglitazone, or insulin. What about patients already taking standard-release metformin? The guideline advises continuing standard-release metformin if it is well tolerated. However, switching to modified-release metformin can be considered if gastrointestinal side effects occur or if the patient prefers it. Now let's move on to lifestyle management. Patients should be encouraged to consume high-fiber, low glycemic index carbohydrates. Low-fat dairy products and oily fish should be included in the diet. Saturated fats and trans fats should be reduced. Foods marketed specifically for people with diabetes are not recommended. For overweight patients, an initial weight loss target of 5 to 10% of body weight is advised. Now let's discuss cardiovascular risk factor modification. For hypertension, blood pressure targets are the same as those used in people without diabetes. For patients under 80 years of age, the clinic blood pressure target is below 140/90 mm of mercury. The equivalent home or ambulatory blood pressure target is below 135/85. For patients aged over 80 years, the clinic target is below 150/90, and the home or ambulatory target is below 145/85. ACE inhibitors or angiotensin receptor blockers are first-line agents. In patients of Black African or African Caribbean family origin, an ARB is preferred. Regarding antiplatelet therapy, aspirin should not be offered routinely for primary prevention. It should only be used in patients with established cardiovascular disease. Finally, lipid management. According to NICE guidance, patients with a 10-year cardiovascular risk greater than 10%, assessed using CRISC-3, should be offered statin therapy. The first-line statin is atorvastatin 20 mg once daily. Thanks for watching 2-Minute MRCP. If you found this helpful, don't forget to like, share, and subscribe to 2-Minute MRCP for more quick revision videos.